So, welcome to tonight's webinar on traumatic brain injury in Australia with our speaker today, Dr. Sarah Hellewell. Just a few bits of housekeeping before we get started. To get the most out of this session, just make sure that your internet connection is as strong as possible. So, check you don't have videos playing on another tab or a different device in the house. If you do have issues, this is going to be recorded and we'll make the recording available as soon as we can. Next, the reactions. You should be able to see these in the lower toolbar of Zoom. So please use them throughout the presentation. We love to see when you're finding something interesting or learning something new. And also in the lower toolbar is the Q&A function. So this is where you'll submit questions for the speaker in tonight's session. So make sure you send them in the Q&A box rather than in the chat. And one great thing about the Q&A function is these thumbs up buttons here that you can see. So if you can like or upvote for the questions that you'd like to see answered, at the end of the presentation, we'll prioritize those with the most upvotes. So keep an eye on the Q&A throughout. So for those of you who are new or don't know much about the Brain Foundation, I just want to quickly introduce a bit about our mission. So our primary goal is to fund high-quality Australian research into brain diseases, disorders, and injuries, with the ultimate goal of improving patient outcomes. Secondly, we provide medically reviewed resources about different brain conditions and brain health. And lastly, we raise awareness about the impact of brain diseases and advocate for patients. So next up, I'd like to highlight a recent announcement related to some of our advocacy work and also to today's webinar topic. So you might have seen the news about 3 weeks ago with Wally Lewis announcing a $12.5 million federal government program for chronic traumatic encephalopathy or CTE awareness. And this funding was awarded to the Concussion and CTE Coalition, which is led by Dementia Australia and includes us, the Brain Foundation, an organisation called Connectors Australia, and Associate Professor Fatima Nasrallah and Dr. Rowena Mobbs, who are two neurologists who work within the Queensland Brain Institute at the University of Queensland. The coalition will develop and deliver a national pilot program of support services for people impacted by CTE and also a national awareness and education program in schools. So this is a really significant step forward in improving the management of concussion and CTE in Australia, and we're looking forward to sharing more about this work over the next couple of years with you. So just to make sure we're all in the right place tonight, who is this webinar for? This is for anyone who's interested in improving their brain health. If you want to learn more about different brain disorders, diseases, or injuries, specifically tonight, concussion and traumatic brain injury, and if you'd like to ask a question. So I'd like to introduce tonight's speaker. We have Dr. Sarah Hellewell. She is a senior research fellow at Curtin University in the Parent Institute in Perth with a career focus on traumatic brain injury. Her research incorporates both clinical and basic science programs spanning the spectrum of brain injury severity, enabling her to rapidly identify clinical problems and translate from the bedside to the bench and back again. Outside of academic research, Dr. Hellewell has worked in military environments where her focus was blast brain injury and biological resilience to injury and stress. And currently she's leading the imaging arm of the National Australian Mild Traumatic Brain Injury, or AUS-MTBI study, to predict long-term outcomes from concussion alongside interventional studies to improve persistent concussion symptoms. And just a quick introduction about me. My name's Anik and I'll be your host for tonight's webinar. I'm the Grants Program Manager and Digital Lead at the Brain Foundation. So I oversee the grants application process and also write a lot of our website articles and newsletters. And tonight we also have Vanessa Mundell here again moderating the chat. So Vanessa is the fundraising manager at the Brain Foundation. And if you have any questions or issues today, just pop a message in the chat and she hopefully will be able to help you. So without any further ado, I will let Dr. Hellewell start the presentation.
Thanks. My name's Dr. Sarah Hellewell. I'm a Senior Research Fellow in Neurotrauma at Curtin University in the Parent Institute, and it's my pleasure to talk to you today about traumatic brain injury in Australia. Firstly, I'd like to give an acknowledgement of the Whadjuk Noongar people. I'm coming to you from their Budja, their land today in southwestern WA. And I pay my respects to their elders past, present and emerging. So today I'll give you a bit of an overview about what traumatic brain injury or TBI is, what kinds of things we can do to prevent these injuries from occurring, our options for treatment or rehabilitation, and then I'll talk about complications and the long-term effects that might occur after brain injury. And then I'll wrap up with a little bit of an overview of the kinds of research that are happening in Australia. So we like to think of traumatic brain injury as a spectrum of injury where we have our mild injuries on one end, or concussions. I'll use these terms interchangeably. Then we have a more severe injury, which we call a moderate injury, or right on the other end of the spectrum, the severe traumatic brain injuries. And these are the kind of things where someone may be in a coma for several days or weeks and will need long-term rehabilitation and often long-term care after their injury. So traumatic brain injury is probably a lot more common than you think. In fact, in Australia, we have at least 200,000 of these injuries occurring every year, but these are only the ones we can count, usually by their presentation to the hospital. So actually this number is probably quite a bit higher. Most of these, in fact, even up to 90% of these injuries are what we call concussion or mild traumatic brain injury at that lower end of the spectrum. For the severe TBIs, we have a mortality rate of 30 to 40%. We have gotten better over time at keeping people alive, stopping them from dying. But as I was saying, these people often need a lot of care. So we expect that less than 50% of people will be able to return to living a life as they did before, and they'll incur quite significant costs as well. And we know now, as we're starting to research children who have concussion more, that up to 1 in 5 kids who will have a concussion or some other form of brain injury by the time they're age 16. So there are several common causes of traumatic brain injury. We hear about sports all the time in the media, but actually sports are only around 16 to 18% of these injuries. We see most often injuries occurring in things like falls, road traffic accidents, workplace accidents, and assaults. And increasingly, we're starting to realize that there's many injuries occurring, unfortunately, to family and domestic violence as well. What happens to the brain when we have a traumatic brain injury? Well, we have several different kinds of injuries that are happening to the brain and several different reactions to this injury that are all occurring at the same time within seconds of injury. We have neuronal injury, damage to the neurons or the cells that send the information around the brain. We have dysregulation of neurotransmitters, chemical signals. We have energy crises where the brain and the cells in the brain aren't getting enough energy to be able to repair and respond to injury. We're not getting enough blood often to the brain, so we're having changes in our blood flow, and we're having problems with inflammation where we're having cells from outside the brain rush into the brain to try and prevent ongoing pathology. So to get more of an idea, I'll show you a video of what this looks like when we have a traumatic brain injury. So this is our brain. We're looking at it from the side view. And if we zoom in on the brain with a technique, this is called diffusion tractography, we can look at these white matter bundles that send information through the brain. We call these white matter tracts. Zooming right in on those, we can see these bundles of axons. Some of them have a fatty coating called myelin, some of them don't. But this is how our brain sends information around. Within the axons, we have microtubules, which are held together with tau fibers. So in this cartoon, we have our microtubules in red and yellow and in blue, and then we have our tau proteins connecting them together. We have little cargo vesicles that are providing support and nutrients. They're carrying them up towards the cell body to provide nutrients and to take away waste. But when we have a brain injury, this becomes disrupted. The axons are stretched and strained. It causes damage to the axon, to the microtubule, and the vesicles can no longer move. So they become trapped at certain points, and we see swelling in the microtubules and damage to this structural scaffolding of the brain. So this can then cause a whole lot of flow-on effects, which we call secondary injury consequences. So I mentioned these axons. This is what they look like in real life. So these are our white matter bundles, and we call them white matter because if we're looking at the brain like this is a post-mortem brain, we can see white matter tracts here are whiter than the grey matter which surrounds it. So these white matter tracts have our neurons inside them. When we have an injury, they get bent like this, and we call them varicose because they look like varicose veins. When we look at them in brain tissue, we can see that some of them become swollen and they stretch, and it's like stretching a rubber band. So they get stretched, but they don't often quite go back to the way they were. And with repeated injury, with repeated stretching of a rubber band, they will become looser and they won't go back to their original formation. Some of them will rupture and they end up curling up like a little ball, which we can see in some of these images here. So, a healthy brain, we have different parts of the brain which are responsible for different senses, different functions, things like concentrating, problem solving, decision making in our frontal lobe. Our temporal lobe is responsible for hearing, for understanding language, for memory. Our cerebellum is where we have a center for balance and coordination. The back of our brain, the occiput or the occipital lobe, is responsible for vision. And our parietal lobe up the top is where we have our seat for touch, control of movement, pain, and temperature. We also have the brainstem down the bottom, which connects onto the spinal cord, which controls some of our really vital functions like brain and heart rate. And these are all working together in the brain all the time to give us normal brain function. But in someone who has a brain injury, they may have changes to any one or multiple of these parts of the brain, which can cause different problems depending on the severity and the type of injury. So for someone who has a concussion, they may have difficulties with focus or attention. They may feel irritable, impulsive. Sometimes people have difficulties with language, with hearing, with vision. They may have blurred vision, difficulties on the more severe end with things like regulating body temperature and spatial perception. And in the very severe injuries, our brain may not be able to regulate our breathing, and we may have difficulty swallowing, and that's if we have damage to the brainstem. So what can we do to prevent traumatic brain injuries? Well, unfortunately, traumatic brain injuries, as I said, are so common. They really are a fact of life that are going to affect ourselves or our loved ones. But there are things we can do to try and prevent brain injuries or to lessen their severity when they do occur. So this includes things like supervising young children, especially when they're using stairs and ramps or they're climbing on play equipment. We can try and prevent falls in the home or the workplace. So things like removing or securing loose mats and cords, installing and using aids like ramps, railings, shower chairs, and non-slip surfaces. In the workplace, we can adhere to safety protocols, wear our appropriate preventative garments, things like footwear, harnesses. Respecting and following the rules is also a big one, particularly in sport. So there are now rules in place in several sports to try and minimize the number of head hits we may have and concussions. And this is also important not only in matches but in training as well. So we want to try and play according to our skill level and try and keep mindful of head injuries and their potential as well. And on the road, we always want to practice our safe driving techniques. So we always want to use our seat belts, have properly fitted car seats, make sure our airbags are working, and drive within the speed limit. When someone's had a traumatic brain injury, there are several different recovery trajectories that are possible. So at the very severe end of the spectrum, we have non-recoverable injuries. These are people who unfortunately pass away from their injuries. At the complete opposite end, we have those who have their injury and recover very well with minimal complications. But actually, the majority of people are here in the middle. We know that there are people who seem to recover well, but worsen over time. There are some people who don't seem to be that affected initially by their injury and they get better quickly, but they get worse over time. We also have people who seem to recover very well. They have late consequences for their injury. And then for 20 to even up to 50% of people who have a mild traumatic brain injury or concussion, we see that they have not a huge amount of symptoms, but they are symptomatic initially, but they just don't get better over time, and we don't know why. So this is what we start to call persistent post-concussion symptoms, or PPCS. So we know that most people will get better over time, but we say from about 4 weeks, if someone is still experiencing symptoms, then we call this persistent post-concussion symptoms. We have no idea at the moment who will go on to develop these persistent symptoms and who will recover well. So there's lots of research in Australia and worldwide to try and understand who's at risk. Ideally, we will find out a particular marker or a particular way to know who is at risk. And then we will be able to say, after you've had a concussion, this person needs this kind of treatment, this person needs that kind of treatment, or this person is statistically likely to be okay. So we don't need to worry so much about that person. There are, we know, some risk factors for persistent symptoms. There are factors like female sex, especially young women, people who have a history of migraines, pre-existing mental health problems, for example, anxiety, people who have a history of learning disability or ADHD, people who use psychoactive drugs, or people who have particular personality traits may be more likely to have persistent symptoms as well. Sometimes these are people who are very high achievers. Sometimes it's people who are quite rigid in their thinking, and this may be a psychological reason they don't get back to their pre-injury self quite as quickly, because they may be stuck in a thought pattern where they believe they won't get better. So, what are the treatments we have for concussion and persistent symptoms? Well, unfortunately, there are no treatments despite many decades of research and a huge amount of money. There are no treatments that can change the underlying brain function and work effectively to prevent the pathology we see in concussion and persistent symptoms. We do, however, have treatments that can target and work effectively on the symptoms we're experiencing after concussion and in persistent post-concussion symptoms. And these are things like having early rest after the injury, having light and gradually introduced exercise. So the evidence now shows that if we rest for the first 24 to 48 hours, we take it easy, we minimize our cognitive load, so we're not watching TV, we're not on the iPad reading books. This will give us a good chance for recovery, but we don't want to rest for too long. The old advice was rest is best, and we must keep resting until our symptoms resolve. Now we know that a little bit of exercise after about 24 to 48 hours is likely to give you a better recovery. So even if the symptoms are still experienced, unless they get dramatically worse, a little bit of exercise, a walk around the block is helpful and may prevent symptoms from becoming chronic. Things like physical therapy, having vestibular therapy and cervical therapy can be very good for people who have things like dizziness as a persistent problem, neck pain and headaches as well. Cognitive therapy, including cognitive behavioral therapy, can be helpful to deal with some of the symptoms and some of the psychological symptoms that people experience after their injuries. And we also have medications that we can take. So for some people, this is medication which may give pain relief. We may take things like antidepressants if depression is a problem. We may have medications to help with anxiety. And we can also take medications for insomnia and a range of other things as well. But as I say, there's no treatment yet which can target the actual brain dysfunction. And so this is where a lot of research is focusing. Now, you may have heard in the media about something called chronic traumatic encephalopathy, or CTE. This is something that's been described more recently in our football and our rugby players. And we're starting to see this becoming a more and more common diagnosis. And it can be very scary to hear about this in the media because you think, well, if that person played football and I play football, then am I likely to have CTE as well? But there's a few things to note. The majority of people won't develop CTE. We don't really know why this is. So there's a lot of research in this field at the moment. But CTE is actually not a new diagnosis or a new phenomenon. We've known about it for decades, but we've called it different things. So, more than 100 years ago, we were calling it dementia pugilistica or punch drunk syndrome. And this was after studying boxers who had suffered repeated blows to the head and appeared as if they were drunk. They were slurring their words, they were having difficulty with their balance. And we thought, okay, well, this is something to do with boxing. But it seems actually that there is a role of repetitive brain injury. Now, there are many clinical, psychological, cognitive features of traumatic encephalopathy that overlap with traumatic brain injury to the point where we actually don't have a living diagnosis for CTE, which means that you can go to the doctor and you can say, I think I may have CTE, but there's no test, there's no way that they can diagnose you with CTE while you're still alive. So we call this a terminal diagnosis because diagnosis can only be made on autopsy when a doctor looks at your brain and they look for very specific proteins. And these are the proteins that we see here. These are called tau. So we can see them close up in the brain. These, we call them tangles. And we can see them in very specific areas of the brain. We see them initially in the base, the sulci of the folds in your brain. We see more of them in the second stage of CTE. And then as we see advanced disease, we see them spreading throughout the brain. So we have no idea yet how many people will develop CTE. We know that it is probably not a huge number of people. It seems like it's linked to repetitive injury, but as I say, not everyone will develop CTE. Not everyone who has repetitive injuries, who has multiple concussions playing footy or another sport, will develop CTE. So there may be other risk factors, and the research is still trying to understand why that is and who's susceptible. We often hear about men, particularly in the media, as being the ones having brain injuries. And when we think about concussions, we tend to think about things like footy injuries, rugby injuries, hockey injuries, car racing, car accidents, young guys hooning around. So we've had this idea that young men, particularly men who in their teenage to early 20 years, are the ones who are most affected by TBI. And so for this reason, we have mostly only studied men when it comes to traumatic brain injury. But we're starting to see now that women are having brain injuries, or we're starting to recognize that they're having as many brain injuries as men, and women are also starting to be more active in contact sports as well. So we're starting to see that they're having concussions through more traditional ways that men do. But we have not until very recently realized that there's a complexity in females who are having concussions and that they're not just slightly different males. The way they respond to injury and the consequences of injury are actually vastly different for men compared to women. So women who have brain injuries may recover more slowly. But men who have brain injuries may have worse cognitive impairment compared to women. Women tend to be better at recognizing how their relationships change and that they're relating to people a little bit more differently after concussion. Maybe it's their personality has changed or they don't want to do the same things anymore. And that can often be a source of distress for women after brain injuries. But men don't tend to report this so much. There's other factors as well, like we're starting to see that women have different immune systems to men, which makes the immune response to brain injury quite different in males and females. But this is only, we're only really scratching the surface of this as we start to understand. But one of the reasons why people have not wanted to study women in the past when it comes to brain injuries is actually one of the most interesting reasons that we should study female responses to brain injuries. And that's due to female sex hormones. So when we look at our ovarian hormones, estrogen and progesterone, We actually find that progesterone is neuroprotective. That means it's going to give protection from brain injury if a woman has a brain injury at the luteal phase of her menstrual cycle when progesterone is high. In contrast, during the follicular phase, when progesterone is low, she may be more susceptible to brain injury. So, this is something that we're starting to really look at and understand, is the disparity in outcomes for women potentially due to their menstrual cycle as well. There's also been some really exciting research recently looking at those microtubules in the axons that we saw before in the video and the differences in males and females. So a research group in the US used a very high-powered microscope called an electron microscope to look at the axons and the microtubules, these black dots within them, see whether there were differences in males and females. And they were looking first in the brains of rats, and they found that actually there were fewer microtubules in females compared to males. And then they looked in humans as well to see if this was still true. And they found that, yes, there are significantly fewer microtubules in female brains compared to male brains. And the size of these microtubules is also smaller in women compared to men. So the upshot of this is that men and women may have different responses to brain injuries because the scaffolding of the brain, the structure of their brain is actually uniquely different. So really it gives greater evidence of why we should be studying female and male responses to brain injury separately and treating these almost as separate conditions. Now, I'd like to finish by talking a little bit about some new Australian research, which is very exciting. So the first study is one we're leading at Curtin University, but it's a national study to try and predict recovery. As I said, we have no idea who's going to recover and who's not, and who will develop persistent symptoms after mild traumatic brain injury. So we have three arms of this study. We have a mobile phone app and online data collection, where we're recruiting people up to 14 days after a concussion or a suspected concussion. We don't need a medical diagnosis here, and we're following people up for after 12 months or until their symptoms resolve. We also have an in-person arm of this study where we're recruiting from hospitals in Western Australia, Queensland and Victoria, and following people up for 1 year via phone. This data is all going into a registry, which is a way of keeping information that relates to people's specific medical data. It's a private way of keeping this information, but it enables us to link it with other health data, for example, long-term health outcomes, and it lets us have further use of the data beyond the lifespan of the project. So I mentioned we have an in-person arm of this study, and that we're looking for some kind of a marker that could tell us what someone's recovery is going to be like. So we're looking at blood and saliva-based biomarkers. We're looking at people's medical history, their injury circumstances and their symptoms. We're looking at their cognitive assessment, their memory, their thinking, their attention. We're doing very complex MRI scans, and we're doing tests for balance and eye movement and head or vestibular function as well. So we enroll people within 4 days of their injury, and we follow them up by phone for up to 12 months to look at what their recovery is like. I also mentioned that we have a mobile phone app. This is built into the HeadCheck app. You can opt in for our AusM TBI research pathway. And the real benefit of this is that you get guided recovery for your concussion that is tailored to your own symptoms and where you're at. So it gives guided recovery to go back to work or school, to commence exercise, and if you play contact sports or team sports, to bring you back to sports as well. You also get this really excellent symptom tracker, which shows you how your symptoms are over time and makes a graph of it. And one of the things we hear most frequently from people who have persistent symptoms is that they have headaches or another symptom, but when they go to the doctor wants to know, well, how many days of a week do you have this symptom? And how severe is it? And can you quantify it? And it's not something people are really able to do, but this is something people can do within the app. So we're aiming to recruit 5,000 people Australia-wide, and you can download the app through the App Store on Android or Apple as well, or use the QR code. Um, some research from Monash University has had some exciting new work trying to diagnose sports concussions. So it's really hard to know sometimes, especially when the injury is subtle, whether the injury is a concussion or not. So this new research from Monash shows that we can accurately diagnose concussion from non-concussion using a blood test, using glial acidic fibrillary protein, or GFAP for short, as a marker. This is a marker of astrocytes, which are structural support cells of the brain. But this research shows that the marker has to be measured in the blood within 16 to 24 hours. So we can see here when it's measured early, we can see specific changes in the blood profile of this marker. But if we measure it later than that, we see a real drop off of the amount of GFAP in the blood. This is a really promising marker for sports concussions. Research also from Monash is looking at injuries caused by domestic violence. We're only really starting to scratch the surface of domestic violence and understand these brain injuries. So this research was looking at people who were healthy controls, who had had another kind of trauma that wasn't related to the brain, who'd had a mild traumatic brain injury, or who'd experienced domestic or interpersonal violence. And they found that people who had experienced intimate partner violence had more symptoms. They had more severe symptoms as well than people who'd had other kinds of brain injuries or other bodily injuries. They had higher levels of a marker of axonal damage, of those axons containing the microtubules within the blood, but there were no changes in our sports concussion marker, GFAP. And the final study I'll tell you about is a study that we're doing here at Curtin University to try and improve persistent symptoms. And this is using a personalised approach to something called neurofeedback, which uses brain waves on EEG to try and guide people to alter their brain activity back to what's normal for their age and sex. So it's quite intensive. We have 3 sessions per week for 6 weeks, and we're looking specifically at people who have persistent symptoms, so who are at least 6 months to 4 years after their injury. And we're really interested in whether this treatment can change things in the brain. As I said, there's no treatment yet that can change the biology, the physiology of the brain. So we're using MRI, cognitive tests, blood and saliva biomarkers and questionnaires to say, can it improve symptoms and can it change brain function as well? So in our neurofeedback treatment, we can see this person has a lot of blue in specific brain areas. What we want to see is green. Green is normal. But lots of blue means this person is underactive in this particular kind of brain activity. We also have a person who has no treatment. This is their baseline after concussion. This person's actually overactive. So this is why it needs to be a personalised treatment, because everyone's brain is different in response to injury. For our person who has the neurofeedback treatment, when we look at them at the follow-up time point after the treatment, we can see their brain is mostly green. So we've had good success. We've had good success for this person in restoring their brain activity. And this also coincided with improvements in their symptoms. For our person who didn't receive any treatment, we can see, though, that brain activity is very much the same as it was before. When we look at the functional connectivity in the brain, getting quite technical now, but functional connectivity of executive function, this is high-level brain function, we can see that our person who had the neurofeedback treatment has had a complete resolution of any deviations from the norm in this brain activity, whereas our person who had no treatment has had a slight improvement but is pretty much the same. So I'll end just by letting you know about connectivity traumatic brain injury. So it may be that you have enjoyed this talk and you want to learn more about traumatic brain injury, you want to find a source for information. Connectivity is really the place to find it. So connectivity helps to connect the Australian community to the brain injury research that we're doing. They have a lived experience advisory group and they can connect to current research projects. On the connectivity website, you can find several short courses which are really helpful. They're free and they're available to anyone to try and increase your knowledge or your interest in traumatic brain injury. So you can take courses on sports related concussion, you can do general concussion short courses, you can do courses in concussion in older adults, excellent for people who are caring for older loved ones or working in aged care. And we also have a free traumatic brain injury massive online learning course, which you can do as well through Connectivity website. If you want to connect with Connectivity, here are the details. You can follow them on all the social media and connect on their website as well. I'd like to finish here and say thanks to our wonderful research team and our funders, and thank you to you for your attention.
Thank you so much for that fantastic presentation, Dr. Hellewell. I'm really looking forward to getting into some of the questions that have been submitted throughout the session. Um, I'll just wait for your camera to rejoin. Hello.
Hi.
Hi, Dr. Hellewell. How are you?
Good, thank you. Thanks for
Yeah.
having me tonight.
No, it's fantastic to have you here, and thank you so much for such a interesting presentation. Definitely covered a lot of ground and all those fantastic different research projects happening in Australia. Um, Now to get into some of the questions. The first one that we've got is from Anne, and she asks, could TBI be related or a cause to ADHD or autism? Are there any links there between neurodivergence and TBI?
That's a great question. So there hasn't been a lot of research on this, but the little research has been done shows that people who are neurodivergent may be more likely to sustain brain injuries. But it may be that people who have been diagnosed, probably not with autism, but potentially with ADHD, may actually not have ADHD. They may have had a brain injury and are having specific symptoms from that injury that have been misdiagnosed because of the crossover in the way persistent symptoms present.
Yeah, that's really interesting. I hadn't heard of that kind of research before, so definitely a lot to learn there. The next question is from an anonymous attendee, and they've asked, how do two parts of the brain become affected in ABI, like the frontal lobe, which was damaged in an accident, and eyesight controlled by the rear lobe? Like, how would an injury, I guess, like if you get knocked here, how would it affect a lobe over here? And sorry, they've actually signed off with their name. That question's from Megan, not an anonymous.
Yeah, so to clarify, for those who are not sure, an ABI is an acquired brain injury. So I saw a little bit in the chat before. So every traumatic brain injury is an acquired brain injury, but not every acquired brain injury is traumatic. So anything that happens to your brain that causes any kind of problem is an acquired brain injury. So that covers things like complications at birth that cause problems as the person is developing. It's things like if someone drowns or has a decrease in oxygen to their brain, if they have a stroke, these are all acquired brain injuries, but not traumatic brain injuries. And so it's a really interesting phenomenon that we can have two parts of the brain which are not structurally connected, that can have brain injury sustained to them. And what we call that is a contra coup injury. And what happens is we may hit our head here, but because the brain is almost like a jelly, sustained in a little bit of liquid between the skull and the brain is actually able to move around a little bit. And when we hit on the front of our head, the brain bounces back and reverberates sometimes against the back of the skull. And that's why we often have injuries at the front and the back, or one side and the other side as well. And the part of the brain in between may be spared.
Okay, that's really interesting. Although a little bit freaky to think about the brain shaking around in there. Um, The next question is from Katie, and she is asking, she's experienced a right subdural hematoma a few years ago in 2022, and she's asked if you have any experience with injuries like this or tips to help brain health for people who've sustained these kinds of injuries.
Yeah, I'm sorry you've had that injury. So this is a subdural hematoma is a bleed that happens, so some damage to a blood vessel that is underneath the one of the outer protective layers of the brain that sit between the brain and the skull. And this is an accumulation of blood. Sometimes, if they're quite large, we have to have an operation to remove them. And they can be quite debilitating. So they often happen in moderate to severe brain injuries, occasionally in mild brain injuries. They can be really difficult to deal with. That there is no treatment to improve the symptoms after having something like this, and unfortunately, the treatment really depends on whether you need surgical intervention or not. So it's more, do we operate if it's a bad one and it's going to have really severe consequences and be a threat to your life, or do we leave it and wait and see if it gets bigger, if it's quite a small one to begin with? But it is a really unfortunate thing to happen, an unfortunate consequence of brain injury sometimes.
Yeah, I guess, yeah, it is tricky trying to manage those things. And it's
Mm.
also individual, yeah, the recovery. I actually have a question that's a bit related to that from Ruth. Um, and she was asking what the definition is for moderate brain injury, because in your presentation you covered severe is kind of that coma level, a mild concussion. But what would be, I guess, like the definition to help people better understand what a moderate injury is?
Yeah, great question. So actually, we don't have any firm guidelines on what is mild, moderate, and severe that we apply internationally. So, or even at the same hospital. So different hospitals may have different definitions. Generally, we say based on something called the Glasgow Coma Score, which is your reaction to verbal commands, to touch, and eye movement as well. A score of less than 13 out of 15. The lower your score, the worse it is. A score of less than 13 would be a moderate TBI, and less than maybe 8 or 9 might be a severe TBI. So we'd look at something like that in conjunction with how, if you've lost consciousness, how long was your loss of consciousness? And if you've lost your memory for the event or before the event, how long that was. But it's really imprecise. So someone who loses consciousness for 29 minutes or less, we would say that's a mild injury. But if you lose consciousness for 30 minutes or more, we would say that's a moderate injury. So really, it doesn't follow logic, really, and it is difficult. So the international community has really been trying to work out whether there are better ways we can understand and classify brain injuries. And so we're now starting to incorporate information about the person's clinical presentation. So, their blood pressure, things like that, their Glasgow Coma Score, their loss of consciousness. So the regular things we would usually do, and to incorporate more brain imaging and blood markers, and to look at also modifiable factors, such as whether the person has good social support and whether they're resilient. And those things can be predictive of what someone's recovery may be like.
Yeah, that's really interesting. Thank you. The next question we have here is from Raju Shakya, and they've asked is if there's any recommendation for supplements to help with TBI recovery, especially to do with cognitive function and memory.
That's a great question. Yeah, there are no approved therapies that we know of that can be taken as a supplement that are going to improve cognitive function and memory and things like that across the board. But there is growing research in this field that we call nutraceuticals, which are nutrients and things like that, and supplements that we can take that we can buy over the counter that potentially could support our brain function. So some of the ones that are sort of most hotly investigated at the moment are things like melatonin, which can be really helpful for sleep. Having a good night's sleep mean that we can have better cognitive function the next day. Things like omega-3 fatty acids are being investigated. Creatine, magnesium as well is something that's being investigated, but there's no really convincing evidence that these are going to make a huge benefit at this stage.
Yeah. It's interesting that you mentioned that because in response to that question from Raju, Sam had mentioned that they were interested in hearing any evidence about creatine
Mm.
or magnesium. So I guess the jury's still out on those, but we look forward to learning more soon, I guess. Um, the next question is from an anonymous attendee, and they've asked if you've lost memory through a TBI, but your brain has healed, is there any way to get the memories back?
Probably not. So, loss of memory, either for things that have happened before, or a loss of, or a not making new memories, and we call that retrograde and anterograde memory. Are very common after brain injury, but usually we see they start to resolve after a couple of days. And some people, unfortunately, especially if their injury is a bit more severe, tend to have quite substantial memory loss from before their injury. And unfortunately, there's nothing we can really do about it. So the brain may heal, which is fantastic, but once those memories are gone, so far we think they're gone.
Okay. Yeah. A tricky area. So in that first couple of days, it might be either way. And then after that, it tends to be a bit more predictable.
Yeah,
Yeah.
that's right.
Mm. The next question is from Lauren, and she's asked, how can we increase the research and funding into women with traumatic brain injuries? There's increasing evidence too that just due to disrupted pituitary functions post-concussion, female hormones have significant negative impacts, and with more women playing contact sports and at more professional levels, there's increased incidence in this area. So how can we increase the research into this? Fantastic, very well-rounded question, Lauren. Thank you.
Yeah, great question. One of the things there's been a really big push is for researchers to be doing the research on women. A lot of researchers still don't want to do this because they think women are too difficult from a biological perspective to work with because we have such shifts in the menstrual cycle. It is very difficult to know exactly what's happening and when, what stage of the menstrual cycle people are in because that the hormones can really influence recovery, but there's just so much we don't know. And because we're not doing this research, we actually don't know. So in our research, for some of our studies, we only work with females because we're really interested to understand why specifically females have often poorer recovery, why they have different inflammatory profiles, and what are the kind of risk factors that are specific to women that can affect their recovery. So I think part of it is awareness. So at conferences and things like that, ourselves and others are often talking to other people and saying, well, if you're not using women in your study, well, why not? And what could you do about that? Could you be working specifically with women, or could you be doing, if you're studying sports, can you also study a women's team as well as studying a men's team? In terms of funding, it can be really difficult to get funding. It is always difficult to get funding for research. To get funding for female research specifically, I think there's been until recently a bit of a mentality of, well, it only affects, if you're only looking at women, then what's the point? But we don't have that same question when we say we're only going to look at males. So I think putting greater emphasis on this, making sure that we have gender parity in our research subjects. So a lot of funding bodies, some in Australia and some overseas, will say if you're doing research either in experimental conditions or in humans, we want to see that you're using females and males, and if not, you need to explain why. So that's a really positive step forward in improving the parity in this research.
Yeah, that's fantastic. It's good to have, I guess, like a multifaceted approach to fixing
Mm.
this. Um, the next question is from Kerry, and she has asked if early cognitive therapy has been shown to lessen the length of symptoms with TBI.
Yes, there is some research which has shown that having early intervention for cognition can be helpful. But the difficulty is that we don't know what someone's specific complaints will be and difficulties will be until later. So what we are starting to see now, we have all these different symptoms that people can have. So some people have cognitive problems, some people will have mood or emotional problems, others will have physical problems, they'll have headaches, they may be dizzy. So what we would ideally like to do is be able to predict ahead of time what someone's problems may be based on their biological profile, because we think certain kinds of damage, certain kinds of biomarkers may be present, which may indicate the troubles someone may have later down the track. And then we would have early intervention, because the risk is that we will have lots of people doing cognitive intervention when they may not have cognitive problems, and they may have cognitive issues early that will resolve naturally on their own.
Okay, interesting. Yeah. Thank you. The next question is from an anonymous attendee, and they've asked if concussion can lead to, I don't know, I'm not familiar with this acronym, but BPPV. Do you know what this is
Yeah,
referring to?
so this is vertigo, and yes, it
Uh,
certainly can.
yes.
So there are quite a good amount of evidence. There is quite a good amount of evidence now that concussions and other kinds of brain injuries can lead to persistent vestibular problems. So that's problems in the inner ear that can cause issues with dizziness and vertigo. So that's something actually that we have a good amount of evidence that we can do something about. So there are physiotherapists that specialize in this inner ear. They're vestibular physiotherapists, and they can be very helpful for people with these symptoms.
Oh, that's great to hear that there's yeah, treatments out there for it. The next question is from Anonymous again. And they have asked, they said they have post-concussion fatigue for 10 months. What should I do now? Should I see a neurologist again or another type of specialist? Yeah, what's the treatment plan there?
Yeah, unfortunately, fatigue is one of the most common persistent symptoms that we see. So we say if you've got symptoms longer than about 3 months, those are persistent symptoms. So they're symptoms you're kind of living with on a daily basis. There is unfortunately no treatment that can help to correct what's going on in the brain that's causing the fatigue. So apart from things like medication, making sure you're getting enough rest, getting enough sleep, trying to balance, if you can, work and social things with sort of restful activities at home, working from home where you're not having to commute or look at the computer screen so much. These are things that can help, but it's more these kinds of occupational health type approaches rather than actual treatments at this stage, unfortunately.
Okay. Um, Great. Thank you for that answer. The next question is from Zoe. Um, and she has asked, I guess this is a little bit related to our first question, actually. Concussion rehab is largely based on awareness of symptoms, questionnaires, and education. Do you have any suggestions on how to adjust our treatment to treat the neurodivergent population?
My short answer is no, but I would really love to. And I think this is really something we've never thought about before. So we have a specific set of things we can do in rehab, in asking people about their symptoms. But one of the difficulties that a lot of people experience is that they lose introspection to how they're feeling, and they're not able to really understand their symptoms. But when you speak to one of their loved ones or someone they live with, someone they see a lot, they can say, yes, I would say you're, angry or depressed, or you're talking about the fact that you're very fatigued, this amount of days of the week or this amount of the time. But this is something that is, going to be also particularly difficult for people who are neurodivergent, who present differently, who may not respond in typical ways to the therapies and the assessments and things that we have. And what we probably would need to do is develop specific tools to assess these people, and take into account their medications as well, because someone who, may have ADHD may take a stimulant medication, which would mean that because of their medication status, they're more active and they're less fatigued. But actually, if we took away the medication, they probably it may be masking some of the symptoms. So we probably need a real think and a strategy for how to assess people and treat them in this context. Yeah.
Yeah. No, there's some interesting considerations there for sure. I'm just gonna have a look at some of these questions from the chat as well. Um, there was there was one from Megan that I thought was quite interesting, asking about long-term pain related to a TBI. Megan's suffered a TBI in 1992, and
Mm.
yeah, like obviously that's quite a long time to be dealing with chronic pain. Is that common with TBI?
It's not common, but it can happen. So, and there's nothing we really can do about it. We don't know why some people have these pain that persists and some people don't. And we don't know what predisposes people to develop these kind of ongoing pain. And it may even be that we are not diagnosing it and attributing it to the brain injury um, in the first instance. So, if someone goes into a pain specialist or a clinic and they say, I've got this pain, and I've had this head injury, but it was so long ago, they probably would say, well, it's not related to that. This is something else. And so we're often not even looking at the root problem. But if we are, there's nothing we can do about it at this stage, which is really unfortunate. So that's taking medications, doing typical physical and occupational type therapies to help improve that, but nothing for the actual biology.
Yeah. Okay, great. Thank you for that answer. The next question is from an anonymous person asking if you can discuss subarachnoid brain injury.
Yeah, so this is a type of hemorrhage like a subdural hemorrhage. It occurs in it's slightly different space. So it's under the arachnoid mater, so a thinner layer of the brain. So it's closer to the brain. It may cause the brain, it may push the brain tissue in. It is something that happens occasionally after brain injury. We tend to see it where there may be a skull fracture or something like that that's causing bleeding. But again, it's bleeding into the space. It is a real medical emergency. It is something that often needs an operation. And these kind of operations, even just the process of taking out the clot and stopping the bleeding, can cause ongoing problems themselves. So, yeah, this is a real unfortunate thing that can happen from a brain injury.
Okay. Great, thank you for explaining a bit about that. The next question, we'll try and fit in just one more as it hits 8 p.m. But Will asks if there are any therapists that specialize with TBI. And yeah, like what are there any specific disciplines that people should be looking for to find someone who really understands it and gets them?
Yeah, this is the real difficulty of brain injury, that we don't have any dedicated professions that are dealing only with brain injury. So we have, we may have vestibular physios, we have physiotherapists, and some physiotherapists are, real experts in brain injury, but they will see other patients as well. So we may have occupational therapists who can help you make adjustments around the house and at the workplace, psychologists, neurologists. So it's really hard to know as a patient where to go and who to see. And if your injury is on the milder side, often the tests that we're doing anyway aren't showing anything. So it can be a really frustrating process. It can be really difficult as a patient to try and get help and to advocate for yourself as well. I think places like Connectivity TBI, their website, which we mentioned before, they have resources and links for specialists and people who may be able to help, information on the kinds of people you could see or the kinds of things you could do to try and get some assistance after brain injury. But there's no kind of one-stop shop per se.
Yeah. Well, that's great to know that there's those, I guess, like services and organizations that can support people through the journey, even though there's not one clear, I guess, like special doctor to see. But anyway, it's ticked over to 8:01 now, so we should probably wrap up for tonight's session. But thank you so much for your time, Dr. Hellewell. It was so fantastic to have you here, and it was a really interesting presentation and a wonderful Q&A. I hope we'll see most of you in tomorrow's webinar on sleep and brain health with Associate Professor Matthew Paze, and that's also at 7 p.m. tomorrow. Thank you so much, everyone. Have a lovely evening.
Thank you.
Thanks.